popular saying, health is wealth, and a healthy nation is a wealthy nation, which is why most governments of the world place premium priority on the health of its citizens. Nigeria is no exception. Now, the Nigerian government, through the National Health Insurance Scheme, NHIS, which took off in the year 2005, set out to improve the general health of public servants on the payments. Oh, what people say as a token. While so many have tapped into the scheme and are benefiting from the initiative, there seems to be a lot of disaffection and complaints about the quality of services being rendered, which is why we will be addressing it on the program today. Of course, so many questions begging for answers. Thankfully, we have a guest who will make his own attempt to answer some of these questions. We'll do the introductions shortly. This is Nigeria Today, and I am Blessing Abu. Welcome to the program. In the studio is an health insurance expert. Let's welcome Dr. Ogeoma Okeka to the program. Thank you for joining us on Nigeria Today.
Good evening, thank you.
Now, before we go into the conversation, setting out our questions, we'll be taking the program to the streets because our correspondents went out earlier, and these are the views that we brought back.
NHIS is very, very positive because he assists people that are unable to pay for their drugs.
It's not the system need to be re-energized and re-orientated. That's what I can say.
In fact, it's more important than only civil servant because those that are civil servant, at least they have a salary to cater for the health of their children. What of those who doesn't have salary? They deserve this thing more than the civil servant.
There are things they could improve on. For example, my wife registered. When we went to National Hospital, they asked us to go to that place again to get a particular confirmation. Even when it is already known that it's a public servant, her office or her passport, everything about her was complete. I don't think there's any need for somebody to register and now be asked from the same hospital, that the hospital that you are going to access the facilities from, to go back again to get any confirmation. It doesn't make sense.
Just improve on like their card they normally give, that's the insurance scheme. Their card, the expiry date should just last for more than 2 to 3 years. Because my own, as from 2 years, my own got expired, so I don't have access to use it again.
Yes, views from the street there on the understanding of the NHIS scheme and people's experience so far. Okay, back to Dr. Ogeoma Okeka. Yes, as an health insurance expert, we expect that some of these areas of strength in the initiative will be brought to the fore. But let's get the nitty-gritty, the framework to this health insurance scheme. How is it supposed to work? What will give us an idea of what it is?
Okay, a health insurance scheme principally is an insurance product, which means it's a system where health risks are put together, premiums are put together, and when somebody falls ill, if he's enrolled on that scheme, that means his money, his premium is in that pool, he gets treated and payment is made to the provider from that pool.
Okay. And this, just like I read a part of the introduction, this in 2005, this just for civil servants and at least those under the workings of the government. But then from the Vox Pop, we just people are of the opinion that everyone should be there. What do you make of that?
The health insurance scheme is not strictly for civil servants. Actually, I'm surprised that even some civil servants think it's for civil servants. The health insurance scheme is for every Nigerian, right? Now, why people think it's for the civil servants is because the civil servants were the first and the easiest to enroll by the federal government.
Okay, so how impactful is this NHIS in terms of expectation to like the SDG goals on universal health coverage? How has it impacted?
I don't think we have done much. I don't think we have done much because the coverage is very low for now. But I'll say, from my opinion, that the issues of the NHIS are foundational.
Okay, break it down for us.
Now, I would say that because, first and foremost, insurance, NHIS is a health insurance scheme, right? It means it is an insurance scheme covering healthcare, right? Which means the legislation, the initial legislation should have been that NHIS should have been on the exclusive list, being an insurance product. That being as it may, right now we failed that, so it's not mandatory because it's on the concurrent list. So that's why we have state governments now setting up health insurance agencies. Now, if it had been on the exclusive list, it would have been mandatory, it would have been compulsory, everybody would have had to pay it, right? Pay at least a premium to start with. But like I said, we've missed that. Secondly, concentration has been on the formal sector. Formal sector being civil servants and those with paid employment. 90% of Nigerians are in the informal sector. Now, those 90% of Nigerians have not been enrolled. To move towards universal health coverage, we must find strategies to enroll this informal sector, market women, traders.
So if you were to give a percentage to those under the insurance, that's NHIS now, as against those who are not, where will your estimate fall?
I think it's better to say those who are covered at all,
okay,
both under the NHIS and the HMOs, is less than 5%.
Less than 5%?
Less than 5%
of the country's population?
Yes, of 160 million people at least.
Wow, that's a far cry from what
we've done like 15 years.
So what do you think are the greatest problems in achieving or moving from where we've been all this while? If something that started in 2005, you're still saying 5%, that's a serious worry.
Yeah. Well, if I would like to split that into NHIS issues,
okay,
industry issues, that's the HMO issues, the providers, which are the hospitals, and the enrollees. Everybody has a role to play in this low turnout, low enrollment. Okay, for the NHIS has concentrated more on the formal sector. They only lately rolled out a few things for the informal sector. Now, when you talk of the informal sector, the traders cannot pay a one-off premium. NHIS has a voluntary scheme, a vital insurance scheme, that's what they call it. That's 15,000 per annum. I don't think that woman selling groundnut on the street can pay 15,000 at a go. So there's a challenge. How are we going to pick up these monies from her instrumentally? That's the problem, NHIS. Of course, there's also the capacity problem.
Okay.
Because since it was being viewed, the scheme was being viewed as a health product, you have not many insurance people in that system. And this is an insurance product. So the NHIS have a lot of people with insurance experience helping to manage the pool. Now, when it comes to the HMOs, the health maintenance organizations, principally, the HMO is a risk taker. The HMO is an insurance firm buying or taking over health insurance risk. It also means that it must have good insurance capacity to take care of the pool that's coming to it.
Do we have that?
I don't think we have that right now. Most HMOs right now are being run by doctors. Like I said, we started looking at it as a health thing. Now, when you come to the providers too, it's a new payment system.
Who are these providers now?
The hospitals.
Hospitals.
Right? The hospitals are being used to out-of-pocket payments, where patients come, they are attended to, they pay out of pocket. Now, in an insurance system, there's a third-party payer, which in this case now is the HMO. So when patients go to the hospital is supposed to take care of them if they are enrolled and send a claim to
the
HMO. Now, most hospitals don't know how to send this claim.
Why? Were they not briefed or
Yes, you see there
when
is
they got
need.
together part of the agreement?
Yes, the agreement is that you should send a claim.
Okay.
And like the word says, it's a claim.
Claim.
The person you are sending the claim to has to look at it and vet it and be on the same page with you. But most of the time, we're not on the same page. The HMO and the provider is not on the same page. The provider, which is a hospital, has been used to giving out services that were never questioned because the person who was giving out those services to is not a professional. So there's an asymmetry of knowledge now. When your doctor says, take this, you take it. But when that claim comes to the HMO has to look at what has been given, and being a manager of a pool of people's money, he has to ensure, the HMO has to ensure that only necessary treatments are given and are paid for. So there's a schism between the HMO and the provider on that basis. Now, let's go to the enrollee. What are his expectations? Does he know what this is all about? A lot of enrollees don't know what their entitlements are and where the limits are, right? So if you don't know where your limits are, your expectations are infinite. So most of the time, once they face a challenge on the other end, on the provider end, they're not happy, right? So, but one of the other issues, major issues that is causing a lot of schism here is the fact that the NHIS, for the NHIS enrollees, pays capitation payments through HMOs,
Okay.
some of which don't get to the provider, unfortunately. However, my position has always been the fact that the NHIS can pay capitation directly to the provider, because capitation is not a risk. Capitation are payments made per head for certain set of services per month, right? So that's the NHIS will be shifting that risk to the provider. I don't think the NHIS needs a third party or a middleman to shift that money.
Okay. Once we get back from this break, Dr. Okeke, we'll address some of this area, what each of this group that you've listed should be doing to have a better grasp of what the total package is all about, and what more the government is setting as an agenda to actually help the better treatment for all of this. And that will be after the break. You're watching Nigeria Today, and we're taking a look at the Nigerian health insurance scheme. How far, so far? We'll be right back after this break.
Advertising your goods and services on the right channel gives you an edge over your competitors. NTA News 24 has all the platforms for your target audience. The station is on DSTV channel 419, GoTV channel 46, StarTimes channel 101, and Free TV channel 703. With our digital format and wide range, we can reach your customers in next to no time. We are eager to promote your business, goods, and services. So partner with us for a very rewarding business experience. For more information, please call Henry on 0803-379-0884 or visit our office at NTA Headquarters, Area 11, Garki, Abuja. NTA News 24. News and more news.
Welcome back. My guest, Dr. Ogelma Okeke, is still in the house, and we're taking a look at the Nigerian National Health Insurance Scheme. And you listed about the 4 levels, as the NHIS, of course, the HMOs, the providers, and also the enrollees. Now, what the enrollees, of course, are at the bottom of this, and they are the key reason why these other ones are in business too. What should be done differently? Because already even the Senate at the sitting yesterday talked about the committee to actually look into allegations being raised about the poor quality, as well as some other concerns that they've raised at their meetings. What should the enrollees do as a matter of urgency to actually get benefits, good benefits for whatever it is being deducted from their money?
Yes, thank you. I think first and foremost, before the enrollee can do anything, he has to be properly informed.
So who is going to do this advocacy?
Okay, this advocacy is three-pronged.
Okay.
The NHIS has to do some generic advocacy, introduce health insurance, talk to people about it, you know, let the enrollees know, not just the enrollees, but everybody in Nigeria should know what health insurance represents. Know what your rights are as an enrollee, because they are, the NHIS is more or less contracted with the enrollees, right? And it's putting them out there, subcontracting that risk to the HMO. So there should be some generic advocacy about health insurance by the NHIS.
Is it going to be through the different companies that have enlisted this one? Because sometimes you get to the hospital, you get to hear, okay, this is where your insurance cover you up to. Perhaps some routine tests. But then once it gets to a particular test, they tell you, okay, no, you can't do this. You might need to call the HMO or whoever it is that at least. Does it differ from company to company, establishment to?
No. The NHIS scheme, the services are divided into primary and secondary services. Okay. You know, I mentioned the word capitation earlier. Yes. Capitation covers primary services. Okay. So when the hospital thinks you require primary services, they don't need any authorization. Okay. But when we are going into secondary services, there is need, because the HMO is carrying this secondary care risk, there is need for the HMO to be informed that your enrollee requires secondary care services, to be informed of what kind of services, why those services, and expected outcomes. Because the provider is eventually going to send a claim on those secondary care services. Right? Now, like I said, if the enrollee is aware of this, of how this system works, he doesn't get shocked, or she doesn't get shocked when the provider says, look, I have to get authorization from the HMO. But when he's at a loss, we're not coming from the past. Healthcare did not used to have to stop somewhere, right, for some authorization if we are paying out of pocket, right? So that's what we're used to, right? Now the systems have changed. So there's a third-party payer now, which is key. So the enrollee himself has to be aware, before even getting to the hospital, that healthcare now, delivery, is divided into sections. So before you move from one section to the other, the HMO has to be informed. And this is the same system both on the NHIS scheme and on the private scheme. Right? It's a managed care system. That's the way the process runs in the managed care system.
But what's your overview generally from the private companies or even the federal or the public companies? What are you hearing from the enrollees out there? Really?
No, there's a lot of dissatisfaction. A lot of dissatisfaction. And I think 80% of this dissatisfaction comes from lack of information. We're not just on the same page. The enrollee is not on the same page with the provider. The provider is not on the same page with the HMO. So there is need for experts to come into this system, inform everybody, and people have to listen.
So funding, it's another area which most agencies or parastatals is okay, this is the reasons why they're not meeting up. Is there a way funding has been a constraint in all of this?
Yes, funding has been a constraint all the way from the NHIS, right? Like I said, it was supposed to be an insurance pool, supposed to be compulsory. Now it's not compulsory, so it's voluntary. At least up till the law is passed, making it mandatory. Now, as it stands, we're going in insurance, the larger the pool, right, the more efficient that pool is. But what are we having today? We have today 37 pools in the formal sector. Each state has a pool, right? Each state has an agency, which means each state is going to have a pool. Now, then you have the NHIS pool. It means you're having 37 pools. But we could have had just one pool if it was on the exclusive list. The states would not have had access to start making laws for health insurance, right? We would have had one very large pool, you know, that could have accommodated everybody. But let me say something here. let us take a figure of 160 million Nigerians. If each Nigerian, whether adult or child, paid 1,000 naira per annum, that pool will be outrageous. That pool will be very, very large. Because we'll be talking of 1,000 naira times 160 million. That would have been the pool, one central pool, right? And that means that would have been affordable, and I'm talking of 1,000 per annum, right? That's one. Two, we need to start to find innovative ways of raising resources for this.
So which will you advance such innovative ways? Because at least someone from NHIS or wherever now could be listening on this program and trying to see what they could do differently. That's perhaps that worked in other climes.
Let me start from the government side. You could pick up money from VAT, from VAT. You could tax luxury products, right? Tobacco tax is there because tobacco is affecting people's health.
Aren't those already been taxed here and there?
Yes, this is a special fund now.
Okay.
We have the education tax fund for education. We can have a health tax fund for healthcare. Now, you could also tax all those who are involved in medical tourism. As long as you want to go and take your treatment outside this country, you might need to drop something into a health pool inside here. That's another thing, right? Now, also let us look at, although this is also belated anyway, if you look at the National Health Act, there's a 1% from the consolidated fund, which now was split into two. One half, 50% to NHIS, 50% to national primary health care. With all due respect, that is like taking money and splitting it into two. One to the demand, half to the demand side, half to the supply side. But I'll say to you that if I were in charge of that fund, I'll put everything on the demand side. The demand side being moving the entire 1% to the NHIS. Because eventually, when it is used to purchase health insurance plans for those in the rural areas, that fund will flow to the primary health care centers. Right? Now, what you are going to see is beautiful primary health care centers, but the people cannot access it because they can't afford it.
So, like I said, part of the Senate's resolve is to see where they can push more budgetary allocation to the primary health care. Will this address some of the concerns, at least before it gets escalated?
Once again, you're going to the supply side, right? You have a beautiful primary health care center, but the woman in the village cannot access. She doesn't have money to go there. The health care center is there, but she doesn't have the money to go there. But if I take that money you want to give the primary health care center and buy her a package, a healthcare package, she's going to get, as she moves into the healthcare center, she's going to move with some capitation payments, right? I'll give you an example. When the MDG program was done, right, a few years back, when the MDG program was done, we were insuring pregnant women and children, right? And capitation was being paid to primary health care centers. And we did a lot of things with it. We built centers with that money, right? That went straight from the from the enrollee and flowed to the primary health care center. So once again, we need to start looking at the demand side.
We must go at just one word. Issue of reforms in the health and issue of health, quality health is key. As we move on, where and what would you want to see for quality health service to be rendered to the people? At least I know you've talked about some of them, but being saddled with this now, it's a matter of priority.
Yes, you see, I would say you need to get healthcare access first before you start talking of quality, right? So people need to be covered first. We need to cover, bring in, enlarge the pool. It is after the pool, after somebody gets access into the system, into the healthcare system, that we now start talking of quality. So the key thing is access. How do we make sure that we achieve universal health coverage? 5% in 15 years. Wow, it's incredible.
It's abysmally low.
Oh yeah, we need to re-strategize.
All right. health insurance expert, Dr. Ogioma Okeka. Thank you very much for coming on the program, and we appreciate your insights. And that's it on today's edition of Nigeria Today, and indeed for the week. We'll see you again on Monday, God willing. My name is Blessing Abu. You can watch this edition online, or that's a particular one or any other one, because Nigeria Today comes to you every day of the week, 7:30 in the evening. Yesterday, youtube.com/NTA News 24 Hub is the address, the link to get to see some of these editions that you've missed. Thank you, and enjoy the rest of the day.